Hi my dear students, today we will be discussing the next part of ANS. Last class I guess Murshad sir had dealt with ANS and the sympathetic nervous system or the adrenergic nervous system where the neurotransmitter was noradrenaline. Today we will be studying about the parasympathetic nervous system and the drugs that act through parasympathetic nervous system. Okay, in the last class, Sir taught you about the sympathetic nervous system. In the sympathetic nervous system, the main neurotransmitter was noradrenaline, but in our class or in our system, that is the cholinergic or the parasympathetic system, the main character or the neurotransmitter is acetylcholine. Acetylcholine. I hope you remember the name acetylcholine. Coming to the synthesis, storage and destruction of acetylcholine. In acetylcholine, now synthesis of acetylcholine takes place within the cholinergic nerve terminals from choline. This choline is actively taken up into the nerve terminal by sodium choline cotransporter. In this flowchart, you should know how acetylcholine is being formed, how it is being stored and how it is being released, and also what are the other inhibitory agents in these steps. First I told you they are formed by binding of acetyl-CoA with choline. That choline is taken up by a transporter, that is sodium choline cotransporter. Here it forms acetylcholine which is later stored inside the vesicle. Inside the vesicle, so the storage part is inside the vesicle. Once it is stored and when it is needed, it is released out into the nerve terminals by the process of exocytosis. Okay, so acetylcholine is being formed, they are stored in the vesicles and they are released out by the process of exocytosis into the nerve terminals where they go and act to the respective receptors. Okay, in this I told you there are few inhibitory points where you should know. First, the choline reuptake. First one, choline reuptake is inhibited by a drug named as hemicholine, and this is the rate limiting step. Second, I told you these are stored inside vesicles. So the drug that inhibits storage of drug into the vesicle, storage of our acetylcholine in the vesicle is nothing but vesamicol. And finally, that drug drugs that inhibit the release of neurotransmitter through exocytosis are botulinum toxin and alpha bungarotoxin. So two drugs that inhibit, two neurotoxins, those that inhibits the release of acetylcholine from the vesicles are botulinum toxin and alpha bungarotoxins. Coming to the metabolism, or once acetylcholine is released inside the, I told you it acts on the respective receptors, but how it is being degraded. Acetylcholine when released is hydrolyzed by when it is released in between the synaptic cleft, it is hydrolyzed by an enzyme called as acetylcholinesterase. Now acetylcholine will be broken down into choline and acetic acid. This is how it is being terminated. Now this choline is taken up by the cotransporter to produce more or the fresh acetylcholine in the flowchart I have mentioned earlier. Now choline is then recycled in the acetylcholine biosynthesis. That is, when acetylcholine is formed, it is degraded by this acetylcholinesterase enzyme. It is broken down to choline and acetic acid, and this choline is taken up by the new formation of acetylcholine. Now the degradation of acetylcholine is blocked by a group of drugs that is known as cholinesterase inhibitors. That is, ഈ പറയുന്ന acetylcholinesterase എന്ന് പറയുന്ന enzyme inhibit ചെയ്യുന്ന group of drug ന്റെ പേരാണ് cholinesterase inhibitors, which includes physostigmins and neostigmin. And also one more point you should remember over here is the cholinergic synapse is very rich in acetylcholinesterase. Therefore, the action of acetylcholine or T half of acetylcholine is very short. So this is not available as clinically. There is no drug like acetylcholine available, because കൊടുക്കുന്ന സമയം കൊടുത്ത് തന്നെ പെട്ടെന്ന് degrade ചെയ്ത് പോകും, because the synapse is very very rich in acetylcholinesterase. Okay, I hope you got with the metabolism of acetylcholine, because this part is very important. ഇവിടെ നമ്മളൊരു ഡ്രഗിനെ തന്നെ ക്ലാസിഫൈ ചെയ്യുന്നുണ്ട്, those which inhibits the acetylcholinesterase, so that the action of acetylcholine can be increased, and also ആ enzyme നമ്മൾ മറക്കാൻ പാടില്ല, acetylcholinesterase. Now coming to the different types of acetylcholinesterase. So this cholinesterase is of two types. One is true acetylcholinesterase and the second one plasma cholinesterase. True cholinesterase are membrane-bound enzymes that are present in the cholinergic synaptic cleft, which hydrolyzes the acetylcholine and other acetylesters, that is methacholine. Okay. Now, if I say this is present in every all, but the second one, that is a plasma cholinesterase, or it can be otherwise known as non-specific pseudocholinesterase, is synthesized in the liver and found in the plasma and intestine. This hydrolyzes benzoylcholine and butyrylcholinesterase esters. Now there will be genetic variation in this type of enzyme. Okay, and there will be genetic variation. This part is important in one drug where it is being hydrolyzed by plasma cholinesterase, since their absence will lead to toxicity. So cholinesterase you should study. There are two types. One is true cholinesterase, where it is found in all the area in this cholinergic synaptic cleft, while plasma cholinesterase is found in the plasma and the intestine. So as I told you, once the acetylcholine is being released out into the synaptic cleft, they go and bind to the receptors. Coming to cholinereceptors, there are two types of cholinereceptors. One is muscarinic and the other is nicotinic. Muscarinic receptors are G protein coupled receptors. They are subdivided into 5 groups: M1, M2, M3, M4 and M5. Now we are interested only with the first 3 groups, as the 4th and 5th one is under study only. More clinical work are done on M1, M2 and M3. We will go in detail with the part of M1, M2, M3, their site and action. Then the first type is muscarinic. The second is nicotinic. Nicotinic is a ligand gated cation channel, where it is subdivided into NM and NN receptors, that is those which are found in the neuromuscular junction and in the adrenal medulla. Okay, these are the two types of receptors for cholinergic drugs or cholinergic system, that is muscarinic and nicotinic, where they are again further divided. Location and action of M1 receptors. M1, then now where they are present? They are present in the CNS, autonomic ganglia and the gastric glands. In the CNS, what all it does, or what are the response it produces? It helps in learning, memory and also other motor activities or motor functions. In autonomic ganglia, it helps in depolarization, and in gastric glands it helps in gastric acid secretion and histamine release. As a result, these are the functions shown by M1 receptor activation on respective sites. Agonist, the name of the agonist, just remember the name of the agonist as specific M1 receptor agonist is oxotrimorin. Coming to the M2 receptors, M2 receptors are mainly present in the cardiac region, that is in the SA node, AV node, ventricle, atrium, etc. So they are mainly present in the heart, and their action is their action leads to either decrease or reduced impulse generation, decrease heart rate, decrease conduction velocity, contractility, and decrease refractory period. These are the actions that takes place on stimulation of M2 receptors in the heart and CNS. CNS action will lead to tremor and analgesia, and is present in some visceral smooth muscle. On stimulation of these visceral smooth muscles, they cause contraction. Then here also the nature is G protein coupled receptors, and you should remember the M2 receptor agonist is methacholine. The drug name is methacholine. Coming to the M3 receptors, when speaking about M3 is, receptors are glandular, mainly present in the glandular area, that is present on the exocrine glands, that is salivary glands, bronchial tissue, and in the visceral smooth muscles like GIT, bronchial, bladder, and vascular endothelium. So all their stimulation will cause contraction. It is also present in the eyes, where contraction of the pupil takes place. So if you summarize, okay, one more thing, in under M3 the specific agonist is beta Nicol. Okay, now we dealt with the receptors, muscarinic receptors M1, M2, M3. You should remember the specific size for M1. If you think of M1, you should remember the first site you should remember is the gastric glands. Second, M2, you should remember it is present in the heart, mainly heart. Okay, and the third one is nothing but glandular, that is all the glands plus visceral smooth muscles. These are the things that you should remember in under the locations of M3, and their action should also be remembered. The next type of receptors, that is the nicotinic receptors. Nicotinic receptors are mainly divided into two types, I told you, NM and NN. NM is usually present in the neuromuscular junction, while NN is present in the autonomic ganglia and the adrenal medulla plus the CNS. Neuromuscular junction, NM receptors on activation, or the response that is produced is contraction of contraction of skeletal muscles due to depolarization at the end plate. And the NN, that is those which are present at the adrenal or autonomic ganglia, will cause prolongation of postganglionic impulses and also release of catecholamines, excitation or inhibition depending upon the site. So nicotinic two types are the NM and NN. NM at the neuromuscular junction, while NN at the autonomic ganglia. As I told you, NN, their specific location is CNS, that autonomic ganglia and adrenal medulla. Now if you what will happen is it causes specific inhibition and excitation, and the nature of the receptor is an ionic channel. The other all were G protein coupled receptor. This is an ionic channel receptor. Okay, agonist is nicotine. Okay, this is the summary of what I told you. The subtypes of the two receptors of cholinergic system. So two receptors that are present for cholinergic system are muscarinic and nicotinic. Under muscarinic, it is subdivided into three: M1, M2, M3, and nicotinic into NM and NN. Here under muscarinic, I told you we are involved, or we have studied only M1, M2 and M3. M1 is mainly neural, that is CNS, and with gastric. Okay, gastric especially in the paracrine cells. Okay, and what M2 especially in the cardiac region, and M3 glandular, where it is present in all the glands and also in the visceral smooth muscles. The all these receptors where they are present should be known, so that the action will be easy for to understand. Nicotinic, I told you, muscle type and ganglionic type. Muscle type is neuromuscular junction, and ganglionic in the autonomic ganglia. I hope this part is clear to you. Okay, this part should be clear and their action should be clear, because this is just the opposite of the action of our last week's class, that is adrenergic system. Avarteyakka nere opposite aanu ee actions. I hope you understand the difference between the two. Okay. Before going into the drugs, I am just mentioning few names about the cholinergic agonist that will act at that will help in the action along with the acetylcholine, or which has similar action to acetylcholine. Okay, they are divided into natural cholinesterase and alkaloids. Cholinesterase includes acetylcholine, methacholine, and beta-nicol. I hope you have, I told few of the names in my few previous slides. Okay, so cholinesterase and alkaloids. Under cholinesterase there is acetylcholine, methacholine, and beta-nicol. Alkaloids: muscarine, pilocarpine, and arecholine. Okay, just to familiarize with the names, I just showed the slide over here. Okay, cholinergic agonist. The classification of drug, there is another classification. I'll come into it in my next slides. Coming to the actions of cholinergic receptors, going into the muscarinic action. Muscarinic action, first we'll go with the eye. Eye is we have, I told you, eyes. Just remember what is the receptor that is present in the eye. I told you it is the M3 receptors. So you should remember M3 receptors are present in the eyes. Circular muscles of the iris, that is ciliary and the lacrimal glands, both. Here you should remember the muscles as well as the glands have M3 receptors. What happens when you stimulate these M3 receptors? There is contraction of the circular muscle fibers causing meiosis. That is, the pupil becomes small. As you see in the picture, kanninte krishnamani cherudagunu. That condition is known as meiosis. While contraction of the ciliary muscles will cause loosening of these sensory ligaments, the lens becomes more convex and accommodation for near visions take place. That is, there will be another chapter on glaucoma where we will be teaching the respective sites for where all these receptors are present. Here you should remember the receptors are present in the iris and the glands plus the ciliary muscles. Also, it helps to open the canal of Schlemm where drainage of the aqueous humor takes place, thereby decreasing the intraocular pressure. And also in the lacrimal glands, as I told you, M3 receptors are present. Stimulation will cause lacrimation. അപ്പോൾ ഒരു കാര്യം നമ്മൾ ഓർക്കേണ്ടതെന്ന് വെച്ചാൽ കണ്ണിൽ കോളിനർജിക് സിസ്റ്റം ആക്ടിവേറ്റ് ചെയ്ത് കഴിഞ്ഞാൽ ഒരു കാര്യം ഉണ്ടാകുന്ന മയോസിസ്, കൃഷ്ണമണി ചെറുതാവുക. രണ്ടെന്ന് വെച്ചാൽ നിയർ വിഷനിലുള്ള ഇത് കണ്ണ് പ്രൊക്യൂർ ചെയ്യും. മൂന്നാമത്തെ വെച്ചാൽ ലാക്രിമൽ ഗ്ലാൻസിലാണ് അത് സ്റ്റിമുലേറ്റ് ചെയ്യുന്നതെങ്കിൽ അവിടെ കണ്ണുനീർ കൂടുതൽ പ്രൊഡ്യൂസ് ചെയ്യും. സ്റ്റിമുലേഷൻ കോസസ് lacrimation. And also the fourth one that you should remember is it helps the drainage of aqueous humor and thereby it helps in decreasing ocular pressure. So this property can be used in the treatment of glaucoma. Now glaucoma is a condition in which there is increased intraocular pressure due to many reasons. One reason may be blockage of canal of Schlemm. Now this drug can decrease or increase the drainage of aqueous humor, thereby decreasing intraocular pressure. So this is the action on eye. Coming to the next important organ, that is the heart. I told you what is the receptor present, what is the cholinergic receptor present in the heart. It is nothing but M2. Remember, M2 exclusively for the heart aanu. Appam parasympathetic supply is only up to SA node, atria and the AV node. Effect of M2 receptors is activation of SA and atria, thereby causing decrease in heart rate and decrease in force of contraction. അതായത് ബാക്കിയെല്ലാം ഇൻക്രീസ് ചെയ്യാൻ ഇങ്ങനെ ഓർത്താൽ മതി. ബാക്കി എല്ലാ സിസ്റ്റത്തിൽ നമ്മൾ ലാക്രിമേഷൻ കൂട്ടുകയാണ് അങ്ങനത്തെ കാര്യങ്ങൾ. ബട്ട് only in the heart everything decreases എന്ന് ഓർക്കുക. In the heart, if you activate SA node and atria, there is decrease in heart rate and force of contraction. At the AV node, it decreases the contraction velocity and increases the refractory period. So heart, remember, it is the M2 receptor that is present in the heart. Okay, coming to the blood vessels. Blood vessels in karyam parayam. When we talk about the blood vessels actually has no cholinergic innervation, or that is the parasympathetic innervation. There is no innervation, but it has M3 receptors in the endothelium, in the vascular endothelium. So since there is no cholinergic innervation in the blood vessels, it is not useful in treating and it is not used as an antihypertensive, or it is not used in treating antihypertensive patients. Now what you see a difference is if you inject, that is if you inject a low dose of acetylcholine into the blood vessels, what happens? There is a fall in BP. And now how this fall in BP takes place? This fall in BP is due to release of EDRF. EDRF is nothing but endothelium derived relaxing factor and nitric oxide, which causes vascular smooth muscle relaxation. Now this is the fall in BP is by the activation of M3 receptors present in the endothelium, which releases this EDRF and nitric oxide. This causes fall in BP. Now once there is a fall in BP, body ki nammalippam fall in BP varumbothekkum there is a reflex, a baroreceptor reflex, which stimulates the adrenergic system. Angane as a result there is increase in heart rate or reflex tachycardia. This is what happens. നമ്മുടെ ബോഡിയിൽ BP കുറയുന്നതിൻ്റെ കാരണം നമ്മൾ externally, exogenously we injected acetylcholine. As a result, BP fall was there, and body should react to the fall in BP. Adrenergic baroreceptor reflex ആണ് adrenergic system activated ആവുന്നു. There is a compensatory increase in heart rate. Okay, this is what happens with the blood vessels. Important point is blood vessels as such has no cholinergic innervations, but the endothelium has M3 receptors. അപ്പോൾ നമ്മൾ exogenously acetylcholine കൊടുക്കുകയാണെങ്കിൽ ഈ M3 receptors activated ആവുന്നു, EDRF and nitric oxide release ചെയ്യുന്നു, vasodilation ഉണ്ടാകുന്നു, BP fall ആകുന്നു. Okay, this is what happens with blood vessels in cholinergic system. Coming to the next organ, salivary glands. ഞാൻ പറഞ്ഞു glands, all the glands are innervated by the M3 receptors. Okay, what happens if you activate or stimulate M3 receptors or salivary glands? Salivary glands also increase in salivation. Increased salivation also there is vasodilation due to the release of bradykinin. Now coming to lungs. Lungsilum mucus glands ഉണ്ട്, bronchial smooth muscles ഉണ്ട്. Stimulation of bronchial, all these are innervated by the M3 receptors. Activation of smooth muscles will cause bronchoconstriction, and activation of the mucus glands will cause increased mucus secretion. So finally the patient will be experiencing clinical picture എന്ന് പറഞ്ഞാൽ M3 receptors activated ആവുകയാണെങ്കിൽ either they will have breathlessness with increased secretion in the mouth. Coming to the urinary bladder, that too is also innervated by the M3 receptors. There is contraction of the detrusor muscle and relaxation of the sphincter, leading to urination. It helps out to urinate, helps in urination. അല്ലെങ്കിൽ I'll tell you something, somebody who has നമ്മൾ അല്ലാതെ എങ്ങനെയെങ്കിലും overdosage of some drug which has muscarinic receptor activation, especially M3 ആവുകയാണെങ്കിൽ how the patient presents with will be, there will be increased lacrimation. കണ്ണുനീരിനെ കുറിച്ച് ഞാൻ പറഞ്ഞു, lacrimal gland lacrimation, salivary gland full of saliva, then your bronchial muscles will be bronchoconstricted, and the mucus glands will secrete out secretion, plus you will urinate. Okay, I hope you understood. Coming to the next gland, that is the gastrointestinal gland. As I told you, gastric smooth muscles, sphincters and gastric glands have M3 receptors, but the parietal cells have M1 receptors which are involved in acid production. Okay, acid production, the innervation is by M1 receptors, while smooth muscles and gastric glands are M3 receptors. Now activation of M3 receptors activated ആയി കഴിഞ്ഞാൽ motility, the motility of the GIT increases, motility and tone increases, relaxation of the sphincter and increased secretion of the gastric glands leading to defecation. Motility increase ചെയ്ത് കഴിഞ്ഞാൽ തന്നെ defecation ആയിരിക്കും എന്ന് ഓർക്കുക കേട്ടോ. But the activation of M1 receptor will cause gastric acid secretion കൂട്ടും. In the pancreas, acinine cells, M3 receptors ആണുള്ളത്, increased secretion of pancreatic juice. And finally our sweat glands also M3 receptors, leading to increased sweating. The innervation is sympathetic in origin, but the action is cholinergic in action. Here one thing you should remember is sweat glands നൊക്കെ innervation എപ്പോഴും sympathetic ആണ്, പക്ഷേ വെളിയിൽ വരുന്ന അത് cholinergic ആണ്. Action will be cholinergic, that is increase in sweat gland secretions. Okay, summary പറയുവാണെങ്കിൽ ഇവിടെ എല്ലാ ആക്ഷൻസും secretions എല്ലാം കൂടുവാണ് muscarinic action stimulated ആയി കഴിഞ്ഞാൽ. I hope you understand. When the muscarinic receptors are activated, all the secretions are increased, motility is increased, and motility is increased, acid secretion, all the glands are increased, എല്ലാ secretionsum കൂടും. That is the final outcome of M or muscarinic receptor activation. Central nervous system, nicotinic action ഉണ്ട്. There are two actions, nicotinic action or effects plus muscarinic effects. Nicotinic effects, it causes ataxia and behavioral disturbances with restlessness, while in muscarinic it causes tremor and convulsions. Coming to the actions of nicotinic receptors, nicotinic എന്ന് പറയുമ്പോഴത്തേക്കും stimulation of the sympathetic as well as parasympathetic ganglia, which ultimately will result in discharge of either acetylcholine or noradrenaline, since there is parasympathetic and sympathetic innervations. Okay, since most of the organs have a dual innervation, the next result of discharge will promote the dominant tone of the particular region. Avada what is more dominant, that action takes place. Now if it is stimulation on NM, neuromuscular junction, there is contraction of the skeletal muscles. Prolonged activation causes fasciculation followed by paralysis. കൂടുതൽ നേരം അത് ആക്ടിവേറ്റ് ചെയ്യുകയാണെങ്കിൽ it leads to fasciculation and paralysis. So here I end up with my first part of this class, that is cholinergic system and drugs. In this class I just dealt with the synthesis of acetylcholine. Today you should do one thing is draw and show me the picture of നിങ്ങൾ 6 പേരേ ഉള്ളൂ അതുകൊണ്ട് കുഴപ്പമില്ല all has my number and we have a common group. Please draw the synthesis of acetylcholine with the respective inhibitors in the picture. Pinna you should know what is the receptors for acetylcholine. There are 2 types and their specific actions. Okay, I hope this class was useful for you and my sound was audible. I'll come with the cholinergic drugs in my next class.